an extra person that's gonna be
Who volunteered as tribute?
Huh?
Who volunteered as tribute?
Odds are it's Tom.
No?
Yeah. No, I tried to.
All right. So traumatic brain injury.
That's what it comes in as.
Okay. TBIs are bad. Okay. We can strive to make them better, but the most important thing is that we do not make them worse. Okay. What makes TBIs worse?
Hypertension.
Hypotension. What else?
Hypoxia.
Hypoxia. So what do you mean by certain medication?
Given, I think it's ketamine.
It's not a contraindication.
One of them.
But it can raise blood pressure, which raises ICP. So, yeah, you gotta be careful with it. Yes, the big ones are hypoxia and hypotension. Okay, so what happens sometimes? People get tunnel vision and it's like, oh, I gotta get that airway, but if it's hypoxic, why you're messing around with that airway? Okay. So, you know, we really have to make sure that the patient is appropriately ventilated and oxygenated, and that does not always happen. I'm sure some of you have seen that. Okay. So, but that makes secondary injuries, and that can mean the difference between somebody living in the Northeast Center or living an independent life. Okay. So, you know, everybody wants to get the tube, but that's great, but you have to make sure that your patient's oxygenated. Put a nasal cannula at 15 liters on them to make sure that they have passive oxygenation. Make sure that you're bagging them appropriately and don't take too long. Or they get a supraglottic. All right, so there's a lot of people with head injuries. Why? Because physics and humans don't always mix, right? And people are doing dumb shit on a regular basis. So we've got motorcycles. It seems like every weekend there's like a motorcycle accident, at least in Dutchess County. Harriman State Park, right? All the time. ATV accidents, boating accidents, just your run-of-the-mill car accidents, being hit by a car, okay? So there's lots of traumatic injuries. Whenever the weather gets nicer, there's more of them, okay? Diving into a pool and hitting their head, okay? So lots of different ways to get TBIs. So here's our brain and our skull, mostly our skull. So we have our top layer, right? Then there's another layer that goes around it, periosteum. So peri means around. Then you've got your meningeal layer, you've got your arachnoid matter. Your blood vessels, your pia mater is the one that's closest, okay? And then you have your brain. So whenever you have a bleed from trauma or any kind of bleed, it goes in a couple of different spaces, right? So it's a matter of, is it between the outer layer of the dura and the skull? Is it subdural, that space, subarachnoid? And you can be in more than one place too, depending on the type of injury. So, all right, so you get dispatched in a motor vehicle collision with a power, with a point. It's high, only 87. Right? One adult patient in the driver's seat, significant damage to the front. Witnesses state the patient veered off the road and struck the pole head on without slowing down. Okay. You're 20 minutes from a level 1, 5 minutes from a freestanding emergency department. Anybody going to the freestanding emergency department? That should be hell no. Okay, that should be your answer. Because what's going to happen? Somebody's going to have to take that patient to the level 1 trauma center, and you wasted a whole bunch of time. They need to be at the level 1 trauma center. Okay. All right. So, what are your two thoughts about somebody directly striking a pole, whatever, without hitting the brakes?
Seatbelt use?
They don't tell us yet.
If not, they weren't in a good state of mind if they didn't even try to hit the brakes.
Okay. So, what did you say?
I was wondering if airbag. I didn't say.
It didn't say yet.
Possible medical emergency before
medical emergency, or suicide, right? Those are pretty much the two things. Or they could be intoxicated in some form, whether it be alcohol, drugs, whatever, okay? Or they overdose while they're driving, because people do that too. Unfortunately, a lot, but,
Are they sleeping while driving?
or they fell asleep, yep. So, all those things, so we have to be alert for, you know, is there some sort of medical emergency going on with this person that just crashed, right? All right, so, there's your car, there's your pole. What are you thinking about in this scene? Yeah, is the pole gonna fall on top of you? Okay. What is on the top of that pole?
Wires.
Okay, what kind of wires are they? Are they
Electrical.
electrical wires? Are they cable wires? Telephone wires that are down? The electrical ones are the ones on top. Do you wanna get hit with that? No, because you die, okay? You do not wanna get electrocuted. It could be arcing in the roadway. You have to be very careful. Make sure that, you know, you don't walk into that. Now, this person can't get himself out of the car, but if there was somebody that was in a car and there were wires down around them, should they get out of the car?
No.
Hell no, they should stay in the car, okay? Because once they put one foot down and the ground's electrified, they're gonna get electrocuted, okay? So they have to wait till the power's on. All right, so that was a pretty high speed impact, I would say, right? And we're looking at, did the airbag deploy? Were they wearing a seatbelt, okay? What about the windshield? Is there scarring in the windshield? And it doesn't come from the inside?
Can't
Is that
tell.
like where somebody's head hit, right? So you're looking at all of these things. All right, so yeah, we know it requires oxygen. And glucose, it likes that too, okay? So brief periods of hypoxia can be very harmful. So you wanna make sure you keep it above 94% of pulse ox, okay? Now, will it be accurate if your patient is also like in shock? No. So at that point, give them high flow oxygen, okay? Because in addition to their TBI, they're also in shock. So things are not going well for them, okay? So extra oxygen is in that case. All right, so what are we doing with ventilations? Yeah, you don't want to hyperventilate them unless they are actively herniating. How do we know they're actively herniating?
Isn't that when like one pupil's blown?
Yep, when pupil's blown, they'll have an irregular respiration pattern, like a Cheyne-Stokes or Biot's kind of breathing. You know, on some tests, they'll ask you about like which respiratory pattern is which, you know. But you will notice it because it looks strange. You know, you're like, huh, they're breathing funny, okay? At that point, you don't care if it's Cheyne-Stokes or Biot's or whatever, because they're breathing funny, that means they have a pretty serious condition. Okay? How do we know if we're being effective with our backing? How do we know we're being effective with our backing?
Capnography and chest rise, listen for lung sounds.
Yep, and our pulse ox, yes.
Lung sounds.
Good. I wish that we had in the field, there's some places that do have it, the pulse oxes that you can put on the forehead, because
If you take the pediatric ones, you can stick it on their forehead and it works.
they actually make them for adults too, but yes. But, you know, that's an option if they're hyperperfused and you wanna get a better idea of their pulse ox, stick it on their forehead, you know? Cause it doesn't really clip to their ear real well.
The pediatric sticky one, where it's their ear, usually stays pretty long.
Yeah, so ear or forehead, and this way you get more of an accurate number. Okay. All right, so the scene is safe, fire department's there, the guy is older than 65, sitting in the driver's seat, seatbelt still in place. Okay, so he was wearing a seatbelt, he's clutching his chest. He's got a large hematoma to his forehead with a complaint of a pain. So, what do we think about that?
Was he having chest pain before he hit?
Exactly, right? So we need to know, what he, you know, if he was starting to have chest pain, that's why he crashed, or he has chest pain because he crashed and hit steering wheel, or from the seatbelt, or whatever, right? Hopefully they'll be able to answer that question. Are you gonna do a 12 lead on this guy? Absolutely, absolutely. Can people have dysrhythmias from trauma? Yes. Okay. Yeah, so they can have all kinds of different things. They can get lots of PVCs because the heart tissue is irritated because it's bruised, okay? But, you know, they can get bruising on their heart just like they can get bruising on their lungs or on their brain, right? Alright, so, primary brain injury occurs when the accident happens. Secondary occurs when they are basically hypoxic, after the injury, okay? So it's our job to make sure that that doesn't happen, okay? We can't do anything about what happens before we get there, but once we're there, we can make sure that they remain oxygenated well, okay? And in terms of documentation, if somebody is there before you, and they move them, they're doing something, they're treating them in some way, whatever the case may be, document it. Because there'll probably be a lawsuit, and you will get blamed for whatever, if you don't document it. Okay? I once had a case where, I wasn't even a medic yet, but my partner was letting me do everything in my planes, and this guy got stabbed, and, as we pulled up, he was walking towards the ambulance. So, put him in the ambulance. We were literally around the corner from White Prince Hospital at the time. And he sued, trying to say that we made him walk. But I had documented, because I wrote the PCR too, that, you know, as we pulled up, he was walking towards the ambulance. So, you know, so that saved us, basically. That, you know, is documented that way. So always document and cover your rear end. Okay. All right. So, hypotension is bad because the brain's not getting perfused, right? So we want to make sure that we have a systolic blood pressure of what? Higher. 110. Okay, so for possible head injuries, we want it to be 110. Okay? What else do we want to do with the stretcher and the head? 30 degrees. Okay? So a lot easier to do when they're out on a backboard, right? So since we don't use those much anymore. But make sure that you do that, and you know, have them up at 30 degrees at least. Okay? So since we don't have blood, you might have to give them a little more fluid. If they don't have a head injury, we want 90 systolic. Okay, because we don't want to pop any clots that might have happened. But with a head injury, we want it at 110 systolic. Okay, you need to remember those numbers because it'll be on the PHTLS exam, okay? And probably fine. All right. So he has no obvious life-threatening hemorrhages. Well, that's good. Patent airway, is able to talk, 20 breaths a minute, clear lung sounds, 94%. He's warm and flushed. Pulse is strong and present radially at 75. He's slightly confused. His GCS is 13. Pupils are equal, round, and reactive. He can't remember what happened before he crashed. Right? You expose, which, you know, don't forget this part because it's really embarrassing when you bring a patient in and you have not exposed them and you miss injuries. Because then the staff is not going to trust you. Okay? So you can't miss big stuff. Little stuff, whatever, but you can't miss big stuff. So you have to expose. He has sternal discoloration and a palpable implant to the left upper chest. Well, what's that? Pacemaker or pacemaker defibrillator. Right? So that tells you that he's got heart problems, right? What does it also tell you that he could be on? Blood thinners, right? So obviously a much bigger concern for bleeding. And the fact that he already has discoloration on his chest, he probably is on. Right. All right. So Is spinal motion restricted indicated?
Yes.
I would think so, right? Could the patient have a TBI?
Mm-hmm.
Sure. Right? He has an airway, he's not going to get an airway, right? Figure that out. Okay. So, he could have a couple different kinds of traumatic brain injury. Mild TBIs include concussions. Football players get this. Okay? You can get this if you fall down and bonk your head. You can get it from a car accident. So sometimes the signs are pretty subtle, and it's hard to figure out if you don't know the person. But Dr. Brooks, remember Dr. Brooks, you do. She taught me something once that was really interesting. She's like, have them do math. It doesn't have to be hard math, simple math. Because if they are concussed, they're probably not going to be able to do it. They might be able to tell you who they are, where they are, whatever, but give them a math problem. Just, what's 10 times 5? And they're not going to be able to do it if they're concussed. So that's just a little, subtle thing that you might be able to figure out if you give them that. Okay. So, some of the symptoms people may get, they may be dizzy, right? They may be nauseous. Might have blurry vision, migraine, their ears might ring, that's the tinnitus, tinnitus. They may have pain from light, right? So kind of like migraines, if you know anybody that has migraines with photophobia, they want a dark room, right? Because the light hurts them. They may have difficulty focusing, forgetfulness, and then fatigue, insomnia, irritability, and depression. That's obviously you're not going to have that in your ambulance, but that's kind of longer term. So, has anybody had a patient that has asked them the same question repeatedly? Yes, that's fun, isn't it? What happened? Where am I? And you answer them, and they seem to take it in, but then 2 minutes later they're asking you. Okay, so that is definitely a sign of a traumatic brain injury. Okay, as to how severe it is, well, we'll see, right? But you go for take their vitals and their mental status. All right, so epidural hematomas. So here's the dura, there's the skull, there's the blood. That usually comes from an artery. Is that bad?
Mm-hmm.
Yes, very much so. Okay, because arteries bleed a lot more than veins do, because it's under higher pressure. Okay, the characteristic of this kind of thing is a lot of times they have a period of lucidity. Okay, so they crash into a tree while they're skiing, and they are seemingly okay, and don't want to go to the hospital or whatever, and then 2 hours later they're dead.
Surprise.
So, yeah, this happened to an actor's wife. I can't remember her name.
Oh, Christopher.
Yes. Right. So that can happen. So, obviously, people are much higher risk for injury like that. But any kind of major mechanism of injury and altered mental status, or they appear initially okay when you're looking at everything that happened, and they should have been. Highly encourage them to go to the hospital and emergency. And then we have our subdurals. Subdural is usually from a lady, and it tends to happen more slowly. It happens a lot to people that might fall. So people that might be intoxicated, fall down, hit their head, and don't remember what they did. Or they do remember, but they thought they were fine. What alcohol do to your liver? That's the other.
Cirrhosis.
Cirrhosis, and that affects how risk factors. Okay, so they're much more likely to leave. Okay, so you have to be aware of that. And, you know, there have been lots of cases where ERs will put the regulars in the back in the corner, and then they go check on them every day because they have something wrong with nobody actually evaluated. So it might not be you. Alright, so who constitutes training and intention? So what happens when you hit something? You go forward, right? You stall this, then you brain dance. Then you go backwards, and then after you brain dance. So there could be a skull fracture, which bone and short into the brain is obviously the brain outcome, right? Most of them is like a depressed skull fracture. Do we want to really copy that, stick our fingers in that? No, because you can put stuff in your brain. That's bad. If you feel something like that, stop feeling it. So they may have bleeding and bruising in the front part of their leg, and they're also on the back. Penetrating is anything that penetrates the skull. Some sort of object. You know it. It could be a knife. It could be an ice pick. It could be lots of things. Okay? Anything that penetrates the skull is great, is penetrating. Depending on where that happens, and where the object is, and if it got found in the brain, depends on how they're going to do it. Obviously, it's not going to have any fun. Alright, so what are our symptoms? Dizziness and pain. Okay? Pickles. We can be headache, unequal, very orbital ecchymosis. What does that also mean? Raccoon eyes. Are we going to see that right away? Probably not. Okay? It takes a little while to develop. They also may have some blurry vision. They may be nauseous and vomiting. And of course, their mental status is a big thing. So, you have to be ready for things to not go so well. Not seriously. Because, what might they do? Time. Seize. Time. Yeah. Seizure coma death. Ever hear that? Yeah. That's what happens with head injuries sometimes. Right? So, you have to be ready to deal with the seizure. So that they just stop seizing. But that also means that their ICD is really not a good thing. They probably will have unlethal pupils. But there are people that are walking around with unlethal pupils as they were because of some kind of eye thing. They will know that because if they've ever seen a doctor, the doctor will tell them that. But it's important to check. You know, got one normal people, one normal. What would our blood pressure be? Unless they've got some kind of other injury that's causing hypertension. So if it's just a pure head injury, their blood pressure will be high. Right? So what happens when you get increased ICP? What happens to the pulse? It goes down. So you get bradycardia, right? And then you get irregular breathing. The other triad is that known as Cushing's triad. Okay? So increased BP, irregular breathing, and bradycardia. Not good things. Okay? And it probably means that the unemployed people, they're probably herniated living. So they're bleeding and it's pushing it. Okay? So what do they need? Like, a hospital with a neurosurgeon, okay, that can go in there and evacuate that blood, right? Because otherwise, they're not going to, when the brain herniates, what, is there room in there? No, right? So when you're bleeding, it pushes it down, like across and then down into the foramen magnum, the hole at the bottom of your skull. Not good. Big eye. Okay? So maybe like a neurosurgeon. Now, you may have seen some, or just to relieve pressure and relieve the brain. We do not do that, right? But, you know, sometimes doctors are in high sometimes people are working in austere environments, like Alaska, for instance. You know, they get the fishing boats coming into port, right? Serious injuries. They're in the middle of nowhere. And it's a couple hours to a real hospital. And they're in some clinic with like a PA and maybe a nurse or maybe a paramedic. So, like, if they had that patient, they may choose to do something like that. Otherwise, they just sit down. So, you know, there are places just in this country that are hours away from the hospital.
New Mexico, we could do it.
New Mexico, Montana, Wyoming, you know, a lot of the West. We're very spoiled here with how close we are to hospitals. Like, you know, we're like, oh no, we're people for 25 minutes away. Try to be like 3 hours and 45 minutes away. Right? So, or we could be in the wilderness.
9 days later.
Alright. So, how do you think they're, if somebody's got unequal people, are they happy?
It could be.
They could be. But are they really making any sense? Right? So if we end up RSI them to protect their airway, what problems are we? All the okay. Right? I'm getting wrong. Right? Alright, so mechanisms for time against our suspicion. Somebody falls down a full flight of stairs onto a concrete road. That hurts. And they're probably going to be injured pretty severely, depending on how they fall, right? If they're elderly, are they going to be far worse off? Sure. Okay. And they don't want them. So, you can fall from standing height if you're geriatric and break your pelvis. Right? Break your femur. Break your thumb. Just from standing and boom on the ground. Because as you go over, you go slip over. So, you know, you get special emphasis all the time, but you have to examine and assess your patient. Alright, on vehicle accidents, which related accidents, and incidents. This is your fault. Alright. So, we're reassessing our patient. That's a problem because he's got to be narrow when he's speaking inappropriate words. Is that concerning?
Yes.
Yes. Breathing at 20 a minute, now he's at 90%. We're giving supplemental oxygen. Better be. Right? At least the nasal cannula can get off without having to do it. Warm and flushed. Pulse is strong, pleasant, waking. Slightly confused, can't remember events, and it's just so he was at 13, and now he's at 11. Doctors want to know what the numbers are initially. Right? So were there odor or purple, right? Was eating?
Exposure? A, B, C, D, E. Exposure.
For your PCS.
Sorry.
What is it for? Are they, no, I don't, right? What are they speaking like, and are they able to, right? So, that's, you know, if the doctor asks you what the PCS is, and it's not 15, you should know where the deficit is. There. So you first want to wait for his wife, but hopefully for his well, that's good, so he's not making sense. We're going to maintain his fine motion restriction, ambulance. What are the first things that we're doing? during our primary, we put them on oxygen. And we did somewhat of an assessment, but now we gotta do more of a detailed assessment. Vital signs, we gotta do a Dextrose, right? Gotta do all that. You gotta get a shot on that one.
No, I just bought a slushie machine. It'll be here tomorrow. I'm in Briggs class. Someone else bring something to put in the slushie machine.
Alright, so vital signs, the Al's heart rate is 8, this is 90, this rate is 20, this and vital signs 6. This blood pressure is 100 over 60. What do we not do? What do I get up to?
So it's up to 110.
So why isn't he tachycardic? Operator. Because of the pacemaker, right? It's set at a certain rate in between two things, and it's not going to move because it's controlled. Right? So, and it's got nothing there. Alright, so he's got a large silicone left of his forehead with some bruising. His pupils are around and reactive. He's got some reddening external area that is probably infectious. So mostly it's his head and possibly his chest. So, if he starts having PVCs because his heart is irritated, oxygen usually helps greatly. It is amazing to watch. Oxygen is a drug, right? So, it does help. Alright, so our brain likes blood, oxygenated blood, and yes. They're having their PVCs, yes. I would try it. I don't like scoop and see if it helps. Because I've had that situation and it has helped. So sometimes they just need that little bit extra. Alright, so we want a minimal cerebral perfusion pressure. And then the only thing that we can pretty much measure is blood pressure, right? In the field, because we don't have any fancy fluids or anything. And decreased oxygen report for the brain is any increased dose. So, what's this formula? Cerebral perfusion pressure. It is made up of the half of this ICP. So, are we going to know our half?
Mm-hmm.
A monitor will tell us. Okay. Other than the ICP. You know, we don't have fancy things. That. But you should know it on normal weeks. So, if you do an ICU rotation and you have a little bit of injury, you're going to see the various, instruments that they have to make. So, normal cerebral perfusion pressure is between 60 and 80. Normal ICP is between 7 and 15. So increasing ICP requires an increase in half to maintain the now it's full, but basically that's what we're talking about, right? So stop. Alright. Has anybody ever transported a patient with a knee injury? Yeah. That's a crazy thing.
That's
So,
gross.
like, people with head injuries, particularly if it's a closed head injury and it's like swelling and bruising, they, well, first what they do is they twiddle the their time with the day. Sometimes you ask people, like, oh, what year is it? I played in, like, 2002. I mean, I can understand not knowing what day it is, because I think it is. But, for the most part, people usually know the year. So that, you know, if there's nobody else around, you don't know what their normal position is. All right, so you may think confused answers, or are they making inappropriate words, unintelligible noises, or wrong. And then our most notable response, and they call it man, they localized pain, they collapse the problem pain. So, do you do this? What's that like? What kind of what is it? And then out, so, very bad. This is bad, this is worse. Or give no response. So I don't know who came up with this, but we all know that you can have GCS of 3 when you get ready, right? But the light's not zero, but it's if you're good. Okay. You can still be alive with a 3, but probably not for 1. Right. So, clinical signs of creation. Well, what people? You know, weakness on one side of the body. That's it, it's. So, run something off the bottom of the foot and the toes curl up. Okay? Babies have it, and that's normal. Adults should not have it. Fishing reflex is what we're talking about on the school trainer. Ceasing of the spontaneous respiratory function. So you may have to bring something up. Okay? So you got to keep a close eye on that respiratory status. Particularly if they're having irregular respiratory patterns. Probably have your bag out when you're ready to go. It's a little bit more basic stuff and have all your advanced stuff out and ready to go because it's probably going to happen. Alright, so what do we want to do? Obviously, we want to prevent hypoxia, so no ventilation is needed, prevent hypertension. And but ready, keep your patients warm. Right? It can happen even though it's hot out. Okay? If you pull somebody out of the river, do you think that water's particularly warm yet? No. Okay? And they're wet, so they can get hypothermia. You want 35 to 40 or so for your end tidal. So that means generally you don't really want hyperventilate that because they're very cool. Check their glucose, because maybe that's the problem. Maybe that's why they crashed their car, right? So make sure you look at that. And then promote venous flora and focal plane. How do you do that? 30 degrees. 30 degrees, right? Alright, so, field triage. Moderate to severe TBI meets the rated criteria. Okay. Eyes on the trauma center, so they need to go to a level. If for some reason you can't get there right away, go to the tube, they can scan them, and then they'll send them to you. So you go to the trauma center, you're ventilating your patient, and you have a new one. He has a subdural hematoma, and his patient is amniotic. So that means taking a piece of the skull out, right, and letting it move. And if they have not stopped the leak, but there's at least space, so that's the problem, right? Space. All right, transfer to the neurobredic motivated with moving preferences. And you also have the wild unmisplaced sternal fracture. So, for the most part, they don't have it. Now, if this man, first of all, he's older than 55, so right then and there, very high risk of complication. What else do we need? What are some of the other comorbidities there? Health problems. Well, he has a known cardiac history, right? So he's got his major. What other things? Well, every patient will pick up different type. So,
Hypertension.
hypertension, high cholesterol, and minimum diabetes. Diabetes, yes, is good for body, and that causes all of that. Even if it's like controlled, it's still bad. Okay? And it's gonna